Up next, we have the Nutrition and QOL Roundtable, which will be an open Q&A with a couple of panelists. We're welcoming back Dr. Lambert from the Huntsman Cancer Institute, who is the Professor of Surgery and Director of the Peritoneal Malignancy Program. We also will be having Deborah Shelton on as a moderator, and she's the Executive Director with the Appendix Cancer PMP Research Foundation. We're also welcoming Jeffrey Whitridge, who is the Clinical Dietitian in the Regional Therapies Surgical Oncology Section at the University of Chicago. We also have on Monica Moorfield, who's an inpatient registered dietitian who's worked with high-tech patients for over 10 years at the Wake Forest Baptist Cancer Center, and Dr. Katie Duckworth, who is the Assistant Professor and Interim Director of the Psychosocial Oncology Program at Wake Forest. And we also will be having Emily Prieb from Huntsman joining us too to help answer. So please welcome our panelists and our moderators. I want to reiterate that this session will go until 2:10, and then we'll open up to the open forum. Thank you so much.
Thanks, Lauren. Emily is actually on the participants list. Can somebody let her into the session? Thanks. Sorry, go ahead, Deborah.
Okay, great. Well, thanks very much to all of the people, all of our healthcare professionals and other panelists presenting in this. It's really my pleasure to co-moderate the Q&A sessions with Dr. Lambert. We do have quite a few questions, so let me just say at the outset, if we're not able to get to your question, please do reach out to us by writing to us at info@acpmp.org, and we'll do our level best to get you answers. But we do, for the nutrition quality of life, we've gotten several questions about nutrition and diet. And so let's maybe Dr. Lambert, we could open with that. Dr. Levine, I believe, spoke to us earlier today, among others, about the role of diet in appendix cancer and in managing the disease. But we've gotten an interesting question or two about how does one balance kind of the advice to eat lots of fruits and vegetables with the medical clinical need for a low fiber, low residue diet following surgery, following bowel resection. Anyone want to take that up?
Sure, I can touch base with that. Generally after the procedure, it is kind of often recommended to take a low fiber diet. I do know that we're always transitioning our patients as quickly as possible back to kind of a healthful diet or a healthy diet that does include more whole grains and fruits and vegetables. Usually in our pathway, we'll see patients about certainly the next week after surgery, and then I'll be following them for that 6 weeks to the post-op visit. And so in that time frame, we're working on appetite, early satiety, and making sure that we're maintaining weight. And certainly in that time period, we're working towards increasing the fiber.
Right. The fiber restriction is temporary. Sorry.
No, go ahead. Sorry.
I was just saying, to reiterate, the fiber restriction is just temporary, just for a few weeks or so.
And could one of you speak to fiber itself? So obviously it plays, I think it's very confusing for people because sometimes it's used as a laxative, sometimes it's used as a bulking agent. There are different types of fiber. And so this question comes up pretty frequently. Can one of you, Monica or Emily, maybe just expound a little bit on how you think about fiber and in what settings and how you recommend using it?
Yeah, I mean, for me, obviously depending on their bowel issues, I always kind of talk about there's a couple different types of fiber. The insoluble fiber is going to have a little bit more of that laxative effect and get things moving. So if you are experiencing diarrhea or something, that's not as much what you want. Whereas you have that soluble fiber, which I feel like can be helpful with diarrhea, coming from applesauce, bananas, white rice, those types of things, but can also block things up too if you do a little too much of that.
So just if I could, that's really interesting. And I'm sure that just in conversations that I have with patients and caregivers, that they will be very interested to kind of understand that the fiber restriction is generally temporary. I know that we, often see things from patients about their concern with small bowel obstruction. And so it seems like long after their surgery, they're still really limiting themselves and staying on a very low fiber diet. So that we can all understand, is that perhaps something that may not be necessary? Is that what I understand?
I think it could
Correct.
be. Go ahead, Monica.
So that is a tough question, partly because if a patient has had a bowel obstruction, that changes things just a little bit. So we would be a little bit more cautious in that fiber restriction. But if a patient has not had sort of the bowel obstruction, we would certainly kind of liberalize the fiber. So I think that was sort of two questions in one. But patients do have a tendency to kind of self-restrict, but we also try to encourage them to get back to a regular diet.
Excellent.
Right.
Excellent. Oh, please go ahead.
Oh, I was just agreeing. And the
Yeah.
focus is, with the bowel obstructions, is really the insoluble fibers, the skins and the nuts and the seeds. And consistency can also play a big part of it. So the softer, closer getting to liquid diet may be necessary for some people.
And Deb, there's kind of a good follow-up question to this topic in the live questions. And this person is asking if somebody after the hightech surgery is still having trouble digesting fruits and vegetables, whether cooked or raw, do you guys have any recommendations for how to get the important nutrients that we hope people will get from these types of foods?
So, you could try blending them up into smoothies. That sort of thing might be tolerated better than especially if it's a bowel obstruction related, partial bowel obstruction related.
Good. And then we have some psychosocial questions too, but trying to consolidate some of the nutrition questions. Anything additional that any of our experts here would add or suggest for patients that have long-term gastro issues? And specifically, we got some questions about, because of the gastrointestinal issues, we have a hard time storing nutrients and therefore we suffer from chronic fatigue. Any suggestions there to maybe help mitigate some of that?
It is specialized to, the specific surgery that they had. So really needs to be focused on, just individualized. It's hard to give broad guidance since it is individualized.
Right.
I would sort of have to agree with that too, in
Yeah.
terms of finding out what the patient really is able to tolerate and kind of working with that patient to be able to customize it a little bit more to get more variety.
Can any of you speak specifically to vitamin B? A lot of these patients, because they have cancer of the appendix, have had a right hemicolectomy. And do you guys have recommendations for replacing vitamin B in that setting?
The recommendation is really just to replete if low. It's not to automatically put them on like B12. So yeah.
And that, I think that's definitely, we would always be monitoring for B12 status. And we actually recently had a patient when we did a workup for a B6 or paradoxal deficiency as well. So that was new to see. And I know that just carrying on, we're also trying to be watching vitamin D level as well.
And then I guess, Dr. Lambert, following up on that, so we've talked a little bit about diet, nutrition, a little bit about supplements, vitamins. How about exercise? We get a lot of questions about that. Like, are there any kind of secrets, if you will, suggestions, tips that might help keep people healthy, long-term survival strategies from an exercise standpoint. Besides do it, I would imagine.
I always just say, get moving however you can, and also thinking about ability too, but just getting the heart rate up a little bit, going for a walk, getting moving kind of helps get the gut moving, things like that. And just finding something you enjoy so it doesn't feel forced.
Right.
Any live,
I can-
Dr. Lambert, or anything you want to chime in on?
Yeah, I mean, I can speak, to this as the surgeon who's seeing people who are going through this type of surgery. I tell people before surgery that, the hightech is kind of like running a marathon, and the best training that you can do for it is aerobic exercise prior to the surgery. And the more fit a person is coming into it, in my experience, and I think most people would agree, they tend to do better after the surgery as well. So, I tell people if they don't smoke, don't start right before the surgery. And, if they do any kind of aerobic exercise, walking or swimming or biking or hiking or whatever, keep doing that. And you will find that after the surgery, it'll be so much easier to get going. It'll help your gut health. It'll help your just your psychological and emotional health, just to be able to get up and moving. And I'm sure that at all three institutions, we all insist that the patients get out of bed either the same day or the next day at the latest, and they're working with PT, and we have them ambulating in the hallway. And I know here half the time our ICU has our patients walk to the floor when they transfer, which is always amazing to me. So yeah, so moving is really the best thing you can do.
Great, good. And I'm just going to keep checking my time here. And so we still have about 9 minutes. So that's great. Let's shift gears if we can to some of the psychosocial kind of questions, concerns, and maybe Dr. Duckworth, this is best for you. I don't know, but welcome all feedback and input. But in terms of fear and anxiety that comes with any cancer diagnosis, managing that, that fear, that anxiety, where it can really become quite paralyzing. And, that's with a diagnosis. And then also we see the same types of issues where people go through treatment, no evidence of disease, but forever haunted by the fear of a recurrence, to where it's really disruptive to everyday life. What are your thoughts about that? Any suggestions, kind of tools that maybe you could offer patients?
Sure, absolutely, Deborah. You're right that I think fear of recurrence is pretty high, understandably, within this population. And so along the lines of the former conversation here, one strategy is to focus on the controllables. So all of those things as opportunities for meaning and pleasure and structure in our lives that we can have some control over, that's a really good thing to lean into. So exercise and, again, just really meaningful activities that we can structure into our day and what we can impose is a big piece of that. I think another piece is acknowledgement and sometimes giving words to those strong emotions that as human beings we tend to avoid or try to compartmentalize. Really be helpful in terms of managing some of those intrusive thoughts. And we've done a lot of really great work here in examining sleep quality and sleep disturbance. And so we know that oftentimes those fears that we harbor and those intrusive thoughts visit us in the still of the night when other things aren't there to vie for our attention. And so focusing a lot on sleep quality and sleep hygiene, and again, exploring some of these things that we oftentimes shield our loved ones from with maybe a professional or someone with whom we can confide, a close friend, is really helpful. And so other healthy activities like exercise and, again, structuring meaningful activities throughout the day can really be helpful in that regard.
Great. And I would think, but tell me if there's a different set of considerations for caregivers and family members of patients. Like, just, on a personal note, I'm a long-term cancer survivor, different cancer, but now I'm the caregiver and spouse of an appendix cancer patient. So my mind, I must say, and I'm sure I'm like many others, goes constantly. Is it the same set of kind of tools that you would recommend for caregivers that are anxious about their spouse's recurrence or whatnot?
Great question. I think there's a lot of overlap, but what's really important to underscore here is that we are really working to put caregivers on the map from both a research and a clinical perspective, because we recognize that they oftentimes have very different quality of life trajectories, and the concerns they have can be very different. And so they, in their own right, warrant and deserve a lot of research and attention. And so in some of the preliminary studies that we've done here, we have found that the trajectories that we see and depressive symptom burdens and quality of life symptom burdens are actually quite different and move at different time points compared to patients. So oftentimes that pre-intervention time point is really hardest on our caregivers. And then the post-surgical time point is harder on the patients, given the physical symptom loadings that they're experiencing. And so I think just recognizing that there are differential trajectories, different time points where patients and caregivers might be struggling more, comparatively speaking, is really important. And then recognizing just the strain a lot of our informal caregivers experience is quite different. And that just the social restrictions and the need to balance really heavy caregiving responsibilities in tandem with other life roles can really take its toll over time. And yet there's a bit of a social stigma, I think, for our caregivers reaching out and saying, I need some help here. I need to talk with someone. And so I think just relieving themselves of that kind of self-imposed burden, or the burden that society sometimes puts on them, just to carry it valiantly without complaining, if you will, is really key. And so again, I think putting their needs on the map, acknowledging that they need to be assessed and have an equal number of services available to them is really instrumental in this point, and just continuing to make those same resources available to them that we do to our patient populations.
Great, thank you. Dr. Lambert, do you have questions, input?
Yeah, so I hope it's okay. Thank you, Dr. Duckworth. This aspect of what people go through just from the cancer standpoint, and then the major surgery, being in a rare tumor, or having a rare tumor, that space, all the unknowns is, I think, exceptionally challenging, for people and their families when they're dealing with appendiceal cancer and pseudomyxoma. And so these efforts that you're doing to look at both the caregiver and sleep and all these aspects are hugely important to the success of any treatment that we may offer. One question that I don't want to necessarily go back to the nutrition, but there is an important question that keeps coming up, and that's the sugar question. So I know Dr. Taraga did make kind of a statement about that in his talk, but I'm going to throw it back to the dietitians here, because we get asked this all the time. What do you get? How do you counsel people about sugar? People are asking if they should avoid all sugar to try to prevent a recurrence. How do you counsel people about that? And Dr. Duckworth, I think this does have an impact on quality of life, because I love sugar.
For sure, I agree.
Emily or Monica?
Monica.
So limiting added sugars for sure. And but overall, like, carbohydrates are still healthy, and just want to focus on whole grains, not refined white flour, that sort of thing. So it's still healthy because all your healthy cells use carbohydrates break down to glucose, and your body uses that to function for energy. So you don't want that cut down. But
I'll always kind of talk about the importance of maintaining weight, staying strong for treatment and for surgery and everything. And, sometimes depending on side effects, the diet's already kind of limited. So then to kind of restrict an entire food group just for the fear of the glucose, just feel like can be kind of problematic. So I'll usually discuss that in more detail.
And I just try to kind of, reemphasize that, whole foods are real foods wherever possible, and, kind of work towards either a low glycemic or anti-inflammatory based eating where, you can control what you can control, and then kind of work towards always improving your eating strategies and what you're doing on a consistent basis.
Yeah. All right, I think if I can just make one final comment. So, you know, our bodies require a certain amount of sugar. Our brain and our heart preferentially use sugar as their source of energy. And if you starve your body of sugar, it's going to get it from other sources. So like Emily was saying, it's going to break down muscle mass to produce sugar to maintain the homeostasis that you need. So all things in moderation. And this really isn't the time to be depriving yourself of every last little bit of joy in your life, right, Dr. Duckworth?
Correct. I concur wholeheartedly.
All right. I think, Deb, we need to move on to the next session, but I want to thank all of our panelists. I apologize for it being short. I think I'm the culprit of that for running over in my talk. But thank you all for joining us.
Thank you.
And
Thank
if
you.
anybody has
for
any
having us.
additional questions on this topic, bring them up in your regional symposiums because we'll have representatives from this group at each session. So thank you.